Hi, I'm Dr. Silber from St. Louis. I apologize that I couldn't come to Paris, even though I wanted to come directly, because I had a neck injection for cervical spine arthritis, and it's really not healing as fast as we thought, and it's going to be a couple of weeks before I can make long-distance travel. Unexpected, I'm sorry, but I'm going to give my talk anyway via video, and I hope this will be okay. So the title of the talk is Ovary Transplantation, Primordial Follicle Recruitment, Ovarian Longevity, and parenthetically, the robust results clinically with ovarian transplantation. So it all starts in the epiblast. This is the early embryo, and that's where germ cell specification first occurs, where you see those cells that are stained green. And then those epiblast cells migrate up to the dorsal ridge, and when they migrate up to the dorsal ridge, that's where they can become PGCs, primordial germ cells. And if it's an ovary, they can become primordial oogonia. And if it's a testes, they become spermatogonial stem cells. So we know that's the basic embryology. Now, as the ovary ages, and we're going to talk about the ovary simply, you can see from this graph that we published about a year ago in Fertility and Sterility that the live baby rate per oocyte, per egg, in a natural cycle, single embryo transfer IVF program with 14,000 cycles is very robust. It's almost 26% per egg in the 20s and early 30s, but then there's a gradual drop to age 35, and after age 35, a precipitous drop in fertility of each oocyte, 10% per year. Now, if we compare natural cycle in this slide to the reported results with ovarian hyperstimulation, either Cobo et al., pregnancy rate per egg and live baby rate per egg with frozen eggs, or similar results that were reported by Patrizio et al. For live baby rate per egg with stimulated cycles, there's a huge difference. There's still a real drop in fertility per egg as the egg gets older, but the stimulation sort of clouds the picture because you get many eggs that really aren't so good. But if you look intrinsically at a natural cycle or natural ovulation, you can see that there is this rapid drop after age 35 in fertility rate per egg. In fact, the live baby rate per oocyte with no stimulation is 26%, and for the index paper with stimulation, it's 6 to 7%. This is not advocating natural cycle or minimal stimulation over conventional hyperstimulation. It's just pointing out that you don't need as many eggs when there's minimal stimulation. But that's not the important point. The scientific point is to accurately know what the true fertility rate is per egg as the age drops. And this is a graph of Cobo's results showing that you need about 40 eggs to have a 90% chance of having at least one baby. And this is another very, very interesting graph from Japan showing the average age of menopause in Japanese women. And of course, it's 51 like everywhere else in the world. But for Japanese women who had a unilateral oophorectomy, just one ovary removed, you can see that the curves almost overlap. So taking out an entire half of the ovarian reserve of a woman doesn't seriously affect her age of menopause other than by maybe a year and a half. So there's some compensatory reduction in primordial follicle recruitment that allows the ovary tissue to last longer when there is less ovary tissue. These are important basic points I want to get through early on in this lecture, and then I can go into more specifics about ovary transplantation after that. Now, what are the worldwide results with ovary tissue freezing? We've looked at everything, all the papers, everything documented, and in terms of documented results, there are over 148 live births from frozen ovary tissue. And nonetheless, this is based on ovary transplantation from tissue that was frozen in young women under age 35, young women with cancers like Hodgkin's and leukemia. We can't say that the results will be this good in older women over 35 because you saw from that graph the decline in the intrinsic fertility of the oocyte. No matter how many eggs there are, and no matter what the ovarian reserve is, the older oocytes have less intrinsic fertility. But at least we can say that in Brussels, Israel, Denmark, and at our center, if we look at our well-tabulated results in series, not just case reports, the spontaneous birth rates vary from 41% to 70%. And so we think that the results are very robust clinically. But that isn't the only aspect of this talk. I want to talk about what we learned about ovarian longevity and what determines how long a woman might be fertile or might still be avoiding menopause. So this is our graph that shows, with many, many cases, we keep showing the same thing, that after the transplant, the FSH begins to come down by about 140, 150 days post-op. Comes down to normal or near normal. At the same time the FSH is coming down to normal, the AMH is going way higher than you'd ever expect for such a small strip of ovarian tissue. And then after 4 to 8 or 10 months, the AMH comes down again to extremely low levels. And despite being extremely low, indicating a very low ovarian reserve, these grafts will last, little pieces of tissue will last for as long as 5 to 8 years. So, summarizing those findings, the sequential drop in FSH levels 4 to 5 months post-transplant, followed by a concomitant rise in AMH, suggests that the time in humans from primordial follicle recruitment to the hormonally responsive state and ovulation is 4 to 5 months. The rise of AMH to higher than normal levels, however, suggests an over-recruitment of primordial follicles right after the transplantation. The over-recruitment of primordial follicles after transplant is consistent with tissue pressure being a regulator of primordial follicle recruitment and ovarian longevity. It's been a mystery for so many years and decades, really. What is it that regulates fetal oocyte arrest, and what is it that regulates primordial follicle recruitment? It doesn't seem to be anything hormonal, but it may be something as clear and simple as tissue pressure based on these results. And I'll go into more findings to demonstrate the validity of that. So the subsequent fall in AMH to very low levels thereafter verifies this interpretation. The unexpectedly long subsequent duration of function of these depleted grafts, and they are depleted, suggests that the ovarian reserve depletes. When that happens, the primordial follicle recruitment in a compensatory fashion is reduced. Thus, these grafts with a low number of eggs last a very long time, and it's probably because of a sudden loss of tissue pressure after transplant and a massive primordial follicle recruitment and return of cortical tissue pressure after healing with a high fibrous tissue to follicle ratio then reduces the rate of primordial follicle recruitment. It's the density and the toughness of the fibrous tissue of the ovarian cortex that regulates the recruitment of primordial follicles, and actually in the fetus is responsible for oocyte meiotic arrest. The primordial follicle is a very, very unique functional structure, which when we make oocytes from iPS cells, from PGCs in vitro, those oocytes don't go through the primordial follicle phase, and they just keep on developing until they're all gone. The primordial follicle prevents all the oocytes from being gone by the time the little girl is born and allows a gradual recruitment of oocytes during the adult female's lifetime. So increasing pressure during oocyte culture should arrest their development and form primordial follicles. In contrast, dissolving the fibrous tissue, which decreases tissue pressure, causes the gene FOX3 to go extracellular from intracellular and thus releases these locked primordial follicles. So cortical tissue pressure, I think, is a key regulator of fetal primordial follicle arrest and adult primordial follicle recruitment and ovarian longevity. So now that I've given you the key points that I think you should keep in mind as we talk about our experience with ovary transplantation and the worldwide experience, as we go through that, keep in mind some of those key points that we come to the conclusion of. And I'll end the lecture by showing you some of the data that came from Japan that's indicating that indeed tissue pressure is a key regulator of ovarian longevity. So just to review, you know that all the primordial follicles are located in the cortex, and the ovarian cortex is the toughest fibrous tissue in the body. If you measure it on a tensiometer, it's just like the tunica albuginea of the testes, and you can measure it objectively, and there is no tissue that is tougher or more dense than the ovarian cortex, which is the same really as the tunica albuginea of the testes. And this is again the graph that shows the critical point about when the pressure is reduced, there's a massive over-recruitment of primordial follicles. Now, you'll note from this picture, again, that these primordial follicles, all located in the cortex, in the outer millimeter of the ovary, really, they develop into primary and secondary and Graffian follicles toward the inside, toward the soft medulla. So the development occurs from dense tissue pressure to less dense tissue pressure, and it's actually automatic. To quote Katsuhiko Hayashi, it's automatic. And this automaticity is regulated by the tissue density pressure. So you can see that if we just take the outer millimeter, just the cortex of the ovary, that's where all the primordial follicles are located. You're not going to miss out on any eggs if all you deal with is a thin outer cortex. So that last picture, which shows you the histology, is the same as this picture that will show you what it looks like surgically when you take out the ovarian cortex. It's a thin piece of tissue that is extraordinarily dense, and it would be as dense and as tough as the tunica albuginea of the testicle, except that it is riddled, so to speak, with primordial follicles, with eggs. So this is just a picture showing you compositely one of the first ovary transplants in which we cut off the entire cortex and replace with microsurgically on top of it a thin cortical strip. And we do it with microsurgical technique, constant irrigation with heparinized saline. We want to avoid adhesions because we know that there will be a follicle depletion from the over-recruitment of primordial follicles. And if you don't do your IVF procedure within 5 to 8 months after the transplant, that's the crucial period, you won't get very many eggs at all because they're very depleted grafts. But these depleted grafts last for 5 to 8 years, and we depend on spontaneous ovulation and spontaneous pregnancy to result in most of our successes. But if you want to do IVF, the time to do it, and Mayreau showed this, is between 5 and 8 months after the transplant. Now, this just gives you an idea of the fresh transplants, how the FSH is variable but returns to normal by 4 to 5 months post-op. And you can see with the frozen grafts, the FSH returns to normal similarly, but a little bit later. So you wonder why that would be. The FSH comes down sooner after a fresh transplant than frozen transplant. That's because with a frozen transplant, we really destroy secondary follicles and primary follicles, and all we're relying on is the primordial follicles. With a truss transplant, there are some secondary follicles that will have survived, and so the FSH will come down somewhat sooner. This is just a typical example of a patient. They're all like this. We showed you the composite graph. When the red line, the FSH, comes down to normal, the AMH, the blue line, goes way over normal and then comes down to extremely low levels, and yet the graft lasts for many, many, many years. These are a few video clips just to show you that after we thaw the strips of ovarian tissue, we quilt them together with 9-0 nylon. I'm not saying you have to do it this way, but this is the way we do it. And you see we quilt it together so we have one composite of several pieces, and it makes it easier to transplant that onto the ovarian medulla. And you can see we turn it around, and we have a beautiful looking graft that's composed of several small pieces of ovarian tissue. Now we want to show you that we put that onto the denuded medulla, again with 9-0 nylon interrupted sutures, because we don't want adhesions and we don't want sutures to get in the way, and we want to be able to be sure that when the follicle ovulates, the fallopian tube can pick it up. So here you can see that we're finishing up the grafting of this composite of several pieces of tissue onto the medulla. And then look at the relationship to the fallopian tube. We want to make sure that the fallopian tube can pick up the egg when it ovulates so that we're not depending on IVF. Now, it may be a little silly, because if you do IVF early enough at the right time, I think that can be very successful. But with us and with Anderson and Mayrow and most of the centers doing this, most of the live births are from spontaneous pregnancies. Now, this is just a very busy table showing our first 13 cases of women under 35, showing the details of the results. And our results are similar with vitrification as with slow freeze. Most of our successes are from slow freeze because that's what we were doing from 1996 to 2006. And then we switched everything to vitrification. Patients might come back 10 or 20 years later to have their ovary transplanted back. And so most of our experience is with slow freeze, and we think it works fine. But vitrification works just as well. With the new era of IVF and cryobiology, slow freezing machines are really becoming ancient, and many IVF programs just don't have them at all. So it's possible that enthusiasts for ovarian tissue freezing will have to eventually do vitrification as we do. And so it's a good idea that you learn how to do it, but it's not the subject of this talk. We can talk about that at some future talk. But I'm sure from our results that vitrification and slow freeze are equally good. Slow freeze will kill about 50% of the oocytes. We demonstrated that in papers we published, I don't remember, 6 or 7 years ago. And vitrification really isn't going to destroy any primordial follicles. But it doesn't matter. If you've got a piece of tissue that has 100,000 eggs and you kill half of them, we've already shown that's not going to really make any significant clinical difference. So we have 11 babies from 7 of 9 fresh transplants, and we have 13 from 10 of 13 transplants that are frozen, and so 24 healthy babies from ovary tissue transplantation. There's a benefit of ovary tissue freeze for cancer patients versus egg freezing. There's less or no time to wait before cancer treatment. There's no problem if chemotherapy has already begun. Mayrow first showed that. It's 1/10 the cost. It's less troublesome going through ovary hyperstimulation, and the patient has the return of hormone function as well as fertility of the eggs. Now here's an example of how long these pieces of ovarian tissue can last. She had her last baby from a tissue that was 38 years old, and it was transplanted to her, and she had spontaneous pregnancies one after another, and she had her third baby from this one piece of ovarian tissue at age 46. So these pieces of tissue can last a long time and really rejuvenate, and that's what this talk is about, can really rejuvenate, in a sense, the woman's fertility. So why do these grafts last so long? Low antral follicle count, very low AMH, and only 1/4 to 1/6 of a single ovary. Why did they last so long? Well, here's a picture of fresh human ovarian tissue pre-freeze. Here it is post-vitrification. You can't really see any difference. And Mayrow did this one transplant with me of a fresh transplant. And in Israel, he decided he wanted to do IVF on this patient. And you can see that there is a fantastic ovarian response. There is no problem with ovarian reserve, and we don't see any loss of oocytes from ischemia. And in fact, we know the ovary is extremely resistant to ischemia, just like skin grafts are. And so we're not losing eggs because of ischemia. We're losing them from over-recruitment. And he calls that burnout. I just call it over-recruitment, same thing. But you can see that if you stimulate at the right time, before the graft has been depleted, you can get a lot of eggs. So again, how does the ovary work? Massive over-recruitment of primordial follicles because of decreased tissue pressure, not because of an elevated FSH, which some have suggested, but that can't possibly be the case because primordial follicles don't respond to FSH anyway. Subsequent depletion of primordial follicles, not caused by ischemia, and tissue transplant lasts for many years despite this depletion. Here is an example of a frozen ovary tissue. We froze her tissue when she was 19 years old, about to undergo Hodgkin's disease, had treatment, had 2 bone marrow transplants, was thought that she was going to not survive. She was a 19-year-old college student, froze her ovarian tissue, telling her we couldn't promise her anything in 1997. And in fact, we thought it would never be of any use, but there wasn't much else we could do. She defeated all the odds, and she was cured of her cancer. And here you see she has 4 babies from that one piece of ovarian tissue that we froze in 1997, not really thinking that it would be of any use. And you can see that her last 2 babies are twins. That was not from IVF. Very low ovarian reserve. We told her she's run out of eggs after she had those 2 babies. And yet she ovulated twice, because obviously when the ovarian reserve is down, if it's still a young ovary, and these are young pieces of ovary, if it's still a young ovary, you can have a high incidence of twins from spontaneous double ovulation because the FSH is elevated with reduced ovarian reserve. Here's a leukemia patient. When she was just 24 years old, we froze her ovarian tissue. It was our first ovary tissue freeze, and we didn't think she was going to survive. She also needed 2 bone marrow transplants to survive. And the oncologist gave us the complete go-ahead that her tissue, when we took it out, was free of cancer, and we had a proper IRB, transplanted it back, and she has a healthy baby now at 44 years of age. And she says to us that if she didn't have leukemia, she didn't meet the right guy or decide to have kids till she was 42. So she probably never would have had kids if she didn't have leukemia because of the natural decline in fertility of eggs, and we were able to transplant a 24-year-old ovary tissue back into her. There she is, I guess 41 years old when she got married and cured of leukemia, and told us she wanted to have the tissue transplanted back. Here is another leukemia case whose tissue was frozen 15 years earlier. You can see she's even shorter than me, and that's related to her bone marrow transplant. But she has 3 babies now. There's a typical graph, a decline in FSH and a rise in AMH, and that graph is still functioning. There is her first baby and then her 3rd baby in 2018. So her graft is still functioning, and she has lots of frozen tissue left, and she's had 3 babies from one graft with spontaneous ovulation with no IVF. So we've already done a transplant on 3 leukemia cases. We have 4 babies from those 3 cases. Been very, very carefully counseled and checked by oncologists. Mayrow reported it first, and we first had the courage to do this based on the work by Anderson, and then our oncologist encouraged us to do it after careful testing of the ovarian tissue. Now you can freeze the tissue for all kinds of things, massive teratomas, and this tissue lasts overnight easily, and it can be sent to you basically in media that's on ice, and it'll still be good to freeze the next day. Anderson first showed that. So this tissue is very resistant to ischemic damage. Also, many healthy women will decide to use ovarian tissue freezing rather than egg freezing. This is a beautiful 35-year-old dermatologist, very, very busy doctor, doesn't have any time to fiddle around with ovarian stimulation in 3 cycles or so, and she just chose to have ovarian tissue freezing as a way of preserving her fertility. And then when she has her tissue transplanted back, maybe in 10 years, when she's found the right man and her life is stabilized, she'll even have hormonal function if she's gone through menopause already. This is a 35-year-old with breast cancer, and she didn't want to have kids till she's 40 or 42 anyway, and she can't because she's going to be on chemo for breast cancer. So even if she didn't have breast cancer, it would have been wise for her to preserve her fertility, and she decided this was the easiest, safest way to do it. This is a woman with multiple sclerosis. She's a neurologist, very knowledgeable, from London, and she decided to go through a bone marrow transplant to completely reboot her immune system, a procedure pioneered at Northwestern University in Chicago. She's cured of her multiple sclerosis, but she flew to St. Louis first to freeze her ovarian tissue. And then she went through menopause, terrible, complications of bone marrow transplant. And then we transplanted her tissue back a year later, and she's menstruating, has a baby, and is very, very happy she did this. So it's not just for cancer patients. Now, what if the patient's already had chemotherapy? The very first report Mayreau did was a patient who had chemotherapy, was basically menopausal from the chemotherapy, froze her ovarian tissue. The point is that after the initial chemotherapy, the leukemia patient may have killed all of her peripheral cancer cells, but there are still going to be some cancer cells in the bone marrow, and she will need a bone marrow transplant most likely eventually. But the chemotherapy initially is not going to kill the primordial follicles. It's only going to kill the developing follicles. So you can't possibly stimulate such a patient to retrieve eggs to freeze eggs. Such a cancer patient, your only choice is to freeze ovarian tissue. So ovarian stimulation, ovary freezing is not an option for such a patient because they're basically in a temporary chemical menopause. But take a look at this. You can see that this is an example that she's got a sclerotic area there on the upper right-hand side where she's definitely lost primordial follicles. But she has lots of primordial follicles left. And when you transplant this tissue back, they'll start ovulating and have spontaneous pregnancies. But you couldn't possibly stimulate her for freezing eggs because she has no developing follicles. So remaining residual left ovary was menopausal after a bone marrow transplant, no cancer cells, not surprisingly, and rare healthy primordial follicles that weren't being recruited. So this is another interesting point, and we'll show you this. So this is that same patient after she had her bone marrow transplant, coming back to have her healthy, so to speak, healthy ovary tissue transplanted back. We took off her existing cortex, and we were shocked to see she was menopausal. She wasn't developing, no primordial follicles were being recruited. But you can see a couple of rare corpora albicans, and you can see rare primordial follicles that survived. So why does that happen? Well, this is what Kawamura first showed, and it's verified by our work, that as the ovarian reserve goes down, as it's reduced, the rate of follicle recruitment is reduced, and eventually you have so few primordial follicles that the few that are left can't be recruited. So you can recruit them by doing an ovary autotransplant with fragmentation, maybe in vitro activation, but probably just the transplantation and reduction of pressure is all you need to try. It's a low pregnancy rate, but to try to recruit those few follicles that you'll always find, at least in the first 3 to 5 years, in a patient who has gone through menopause and is no longer recruiting primordial follicles. Now, this was first shown by Bischoff and Anderson in Copenhagen years and years ago, before we even thought of the practical aspects, that in the fetal mouse, it's the oocytes that migrate to the cortex that become small follicles that are preserved and don't die off, and the rest of them do die off. So it's that cortical tissue pressure that prevents at least the fetal female from losing all of her eggs as she goes into meiosis and develops through meiosis. And it also regulates the gradual release of primordial follicles over the woman's lifetime until she goes through menopause. So what controls the recruitment of follicles in adults from the resting phase? It's this gradual release from the fibrous cortex, just like in the fetus. Now here's just a surgical example. You can see the very, very, very dense tissue of the epithelial surface of the ovary graft. And then you go a little farther inside and you see it's less dense. And the least dense tissue is on the inside of the cortex. So there's this gradual decrease in tissue pressure that is what regulates the gradual release of primordial follicles. So this can also explain late menopause in multips. And think about the horse ovary. When a woman is pregnant, Teramoto showed that her AMH stabilizes and doesn't go down like it normally would over that period of time. It's a very minor difference, but in huge numbers of patients and good statistical analysis, he's fairly convinced, and I'll show you his results, that pregnancy, as Dr. Liang from China said, puts the ovary to sleep. And why does it do that? Is it hormonal, or is it just the increased intra-abdominal pressure? We know, I'm a urologist, increased intra-abdominal pressure causes hydroureter, and there are obvious pressure changes and even pulmonary embolus from pressure changes in the vena cava. We know that there is increased abdominal pressure, which has its consequences in pregnancy. And one of the consequences may very well be the shutting off of primordial follicle recruitment, which may explain why multips have such late menopause. So here was Shiramoto's baseline graph of the drop in AMH over age. And here's what he showed when patients were pregnant and came back later for another antral follicle count, another attempted pregnancy. He found that the AMH did drop a little, but did not drop as much as would have been predicted from his baseline graph. So what is it that locks and releases the primordial follicle? Well, we know from dead tissue in menopausal women that there are always a few primordial follicles left, and the eggs are pretty good, and Kawamura has had pregnancies from these eggs. And the conclusion is that ovarian longevity is related to tissue pressure, and without that tissue pressure, if you were just culturing oocytes in vitro made from iPS cells, you would lose them all immediately, which is why now Hayashi is actually going in the reverse fashion and trying to take these PGCs and developing oocytes and increase the pressure in the incubator to see if he can create primordial follicles and create an artificial ovary. What if we were to bypass that primordial follicle? This is what Hayashi's shown. It's absolutely brilliant and impresses me, that he's reconstituted the entire cycle of the mouse female germline. I was there when he did the C-section on the first mice that were born from this procedure, and they have baby mice and they grow up to be fertile. And this is maybe a long slide showing you his steps in culturing skin cells to iPS cells to PGC, to epiblast-like cells to PGCs to oocytes, and eventually to mature those oocytes in vitro. It's really quite fantastic, and he makes it simpler than it really seems. But here's what he shows, is that in vitro, we skip the primordial follicle phase and we have a rapid development of the primordial follicle into a mature oocyte. But in vivo, we don't. We have a rest of that oocyte at the primordial follicle stage, and the way the primordial follicle works is it has a nuclear localization of the gene FOX3, and if you remove the fibrous tissue from that ovary, he's shown that FOX3 goes extranuclear, and then you can recruit from primordial follicles, you can recruit oocytes that otherwise would have been locked. Elimination of extracellular matrix induces nuclear export of FOX3, and so that's going to lead to an unlocking of the primordial follicle. So in vitro oogenesis so far fails to produce primordial follicles, but maybe it will be when he increases the pressure. Primordial follicles acquire the dormant state at the perinatal ovary, and candidates of transcription factors involved in acquisition of the dormant state have been studied, and the trigger for these transcription factors, such as FOX3, might very well be tissue pressure. So extracellular matrix and cortical tissue pressure control primordial follicle recruitment and ovarian lifetime. And we also can tell you that we have very robust clinical results, but the import of this talk I was asked to give was the scientific implications of our work. So thank you for tolerating my doing this by video conference and not being able to come to Paris. I'm enthusiastic about the subject, but I can tell you right now I hurt really, really terribly. But my neurosurgeon tells me the pain will be gone in 2 weeks, but I just was not allowed to travel, and I apologize for that. I love the Ovarian Club and everyone that's organizing it. So thank you very much from St. Louis. This is Dr. Silber signing off.